Thank you, Dr. Samantha, sir. I would like to thank IAS and Punjab Ophthalmic Society for giving me this opportunity. Uh, Although this talk was not uh, listed in this session, but sir asked me to present this. I prepared this talk for some PG students. So I will be talking with you on causes of acute red eye. Acute red eye is a frequent cause of presentation to eye clinics and general OPD clinics. It is a sign of ocular inflammation. It is generally seen in self-limiting conditions like ocular allergies, conjunctivitis, etc. But it could be a sign of potentially sight or life-threatening conditions such as orbital cellulitis, acute angle closure glaucoma, keratitis, scleritis, uveitis, uveal tumor, and endophthalmitis. So there are some red flags of acute red eye. We should, when we everybody when examine a patient or encounter a patient in OPD with acute red eye, so these signs you should look for always. Keep in mind: reduced visual acuity, photophobia, moderate to severe pain. If the patient is having headache and nausea, elevated IOP, corneal epithelial defects, corneal infiltrates, anterior chamber inflammation, there is evidence of foreign body or penetrating trauma to the eye, and there is anisocoria, then different size of both the pupils, then shallow anterior chamber, or if there is proptosis with painful extraocular muscles. Then we categorize the causes of acute red eye depending on the structure involved. Basically, etiology: lids, blepharitis, marginal keratitis, trichiasis, chalazion, striae, subtarsal foreign body, canaliculitis, or dry eye syndrome. And conjunctiva part, it could be conjunctivitis, which could be many types like bacterial, viral, allergic, subconjunctival hemorrhage, pinguicula, pterygium. Then coming to cornea, there could be various keratitis like bacterial, herpetic, fungal, acanthamoeba keratitis, foreign body on the cornea, abrasions on the cornea, or chemical injuries. Then in anterior chamber part, there could be anterior uveitis or acute angle closure glaucoma. Other disorders like herpes zoster ophthalmicus, episcleritis, scleritis, orbital cellulitis, preseptal cellulitis, dacroadenitis, and dacrocystitis, they all present with acute red eye. Now in the clinical evaluation, you should visual acuity should be noted in every patient. Then in the eyelids, you look for edema, erythema, telangiectasia on the lid margins, discharge, presence of scales and crusts, vesicles. Look for legophthalmos and proptosis. Always evert upper eyelid to check for foreign body beneath the eyelid. Conjunctiva part, you should look for congestion, whether the congestion is diffuse or circumcorneal, chemosis, presence of follicles, papillae, discharge in the fornices, any nodules, conjunctival tear. In the cornea, look for any epithelial defects, dendrites, erosions, subepithelial infiltrates, corneal edema, DM folds, foreign body inside the cornea, any infiltrate or abscess in the cornea, stromal haze, keratic precipitates, corneal abrasions or corneal tear, and there could be sensation loss. Globe tenderness should be checked by gentle digital pressure, but it should be always be avoided if penetrating injury is suspected. In the pupils, always look for size, shape, and reaction to light, presence of RAPD, relative afferent pupillary defect. Then anterior chamber, you look for cells, flare, synechiae, hyphema, and hypopyon. Eye movement should always be checked because in orbital cellulitis and preseptal cellulitis, they will be restricted. They will be restricted in orbital cellulitis and they will be normal in preseptal cellulitis. Lymphadenopathy, always look for tender palpate for periauricular lymph nodes. You usually seen in viral conjunctivitis. Then complete fundus examination is mandatory in every case. So if we, I'm just skipping the part, I'm going to discuss viral keratitis. I think this is a very lengthy slides. So just herpetic keratitis. Herpetic keratitis is the most frequent cause of corneal blindness in the United States, most common cause of infectious blindness in the Western world. Approximately 2 million people worldwide have impaired vision from herpetic eye disease. Pathophysiology, there is primary infection which usually occurs most commonly in the mucocutaneous or ocular distribution of the trigeminal nerve and can present as a non-specific upper respiratory infection. Then virus spreads from infected epithelial cells to the cell body in trigeminal ganglion, where virus persists indefinitely and in a latent state. Then Reactivation of herpes virus can occur any time in the body in the lifetime, and there is interneuronal spread of HSV within the ganglion cells, which allows patients to develop subsequent ocular disease without even having primary ocular HSV infection. So primary ocular herpes usually occurs in childhood, uncommon during first 6 months of life. Mostly infection is subclinical or cause mild fever, malaise, or upper respiratory tract infection. Ocular manifestations are generally acute follicular conjunctivitis, keratoconjunctivitis, or periauricular and eyelid skin lesions. Earliest involvement is diffuse punctate keratopathy. These lesions are mild and self-limiting. Then we have various types of herpes simplex virus keratitis like epithelial, stromal, endothelial depending on the layer of the cornea involved. Epithelial involvement, the most common presentation is, the earliest presentation is corneal epithelial vesicles, and most common presentation is dendritic ulcer. Dendrites are the branching linear lesions with terminal bulbs, and there could be other associated features like reduced corneal sensation, mild subepithelial haze, and follicular conjunctivitis. Then dendritic lesions, they coalesce to form geographical ulcers if we give steroids to the patient and patient is misdiagnosed as some other infection. Then in the stromal part, there could be necrotizing or non-necrotizing stromal keratitis. In necrotizing stromal keratitis, there occurs active viral replication within the stroma, which is generally immune-mediated. So it is characterized by epithelial defect, stromal necrosis and melting. There is dense stromal infiltrate and associated anterior uveitis with capes underlying the area of active stromal infiltration. So it leads to, it is very aggressive kind of melting occurs, corneal thinning and perforation occurs. There is a lot of scarring in the cornea, vascularization and lipid deposition occurs in later stages. So it should be aggressively treated with antivirals and topical antibiotics and cycloplegics. And conjunctival flap and cyanocaride glue in cases of perforation should be attempted. Then immune stromal keratitis. Viral antigen in stroma triggers intrastromal inflammation. In this case, the overlying epithelium is usually intact. So it is characterized by stromal edema, vessel immune rings, stromal neovascularization, and lipid keratopathy. Again, the complications are disciform keratitis and scarring of the cornea. So again, aggressively treated topical steroids and topical antivirals. Oral steroids are given in severe cases. Endothelitis. The pathogenesis is unknown, may be immunologic. It is called as disciform endothelitis. There is a round cone-shaped zone of stromal edema, and on examination you see the capes behind the area involved. So basically the patient complains of blurred vision with halos around the light due to the corneal edema present. And later on, neurotrophic keratitis is the severe known infectious degenerative disease of corneal epithelium characterized by impaired healing. Absence of corneal sensitivity is the hallmark of NK, which ultimately leads to corneal stromal melting and perforation. There are lot of causes of corneal hyposthesia: herpes keratitis, leprosy, congenital, familial dysautonomia, Gorlin syndrome, Mobius syndrome, topical medication abuse, then anesthetic abuse. Most common is cocaine abuse. Then we use lot of topical drops like timolol, betaxolol. They all cause diclofenac sodium. They all cause corneal hyposthesia. So various types of corneal dystrophies, regular long-term contact lens wearers. Then there are some corneal incisions, surgeries, chemical burns, and trauma to ciliary nerves during vitrectomy and photocoagulation. Increasing age, diabetes, vitamin A deficiency, and drugs like narcoleptics and antipsychotics. They all cause reduction in corneal sensitivity. Then again, fifth nerve palsy due to neurosurgical procedures damaging fifth cranial nerve. There could be neoplasms. Acoustic neuroma is the most common. Then aneurysms, facial trauma, multiple sclerosis, stroke, and congenital hypoplasia of the trigeminal nerve. Again, I will just emphasize on in the management part of neurotrophic keratitis, we should emphasize on the prevention of epithelial defects because of profoundly impaired healing of the epithelium. Depends on the epithelial condition at initial presentation and the degree of corneal hyposthesia. An epithelial defect in the setting of corneal anesthesia is a serious ocular condition requiring prompt and aggressive therapy to prevent ulceration and possible perforation. There are various treatment options being tried in neurotrophic keratitis like preservative-free artificial teardrops, therapeutic soft contact lenses, topical autologous serum application, amniotic membrane grafting, conjunctival flap, lateral tarsorrhaphy or botulinum-induced ptosis, topical nerve growth factor application, silicone punctal plugs, antibiotic eye drops, cyanoacrylate glue, and DALK or penetrating keratoplasty if there is perforation and perforation of the cornea. If you allow me, I can just discuss with you acanthamoeba keratitis also. It is caused by free-living organisms known as acanthamoeba, commonly found in water, dust, and soil. They prey on other microbes. They exist in two forms. More vulnerable form is the freely mobile trophozoite form. Characteristic double-walled cyst, extremely resistant to extremes of temperature, desiccation, irradiation, antimicrobial agents, and other changes in environment. So, basically, risk factors are most common is contact lens wear, seen in more than 90% cases of acanthamoeba keratitis, responsible for more than 90% cases of. Then trauma, swimming while wearing contact lenses, non-compliance with CL contact lens disinfection systems, and water contamination and warmer climates. Then minor risk factors like steroid use, topical anesthetic use, and use of cosmetics. One of the specific and important symptoms of acanthamoeba keratitis is the severity of pain in the early stages of infection. That is because of radial keratoneritis, epithelial erosions, and pseudodendrites. There could be severe anterior and posterior scleritis. Stromal infiltrates are normally seen, and limbitis is typically seen in acanthamoeba keratitis. Anterior uveitis that leads to transient hypopion. Medical management, biguanides are the first line of treatment. That is polyhexamethylene biguanide and chlorhexidine. Then other drugs used are diamidines, propamidine, hexamidine, neomycin only effective with additional drug to polyhexamethylbiguanides. Then antifungal agents, voriconazole and posaconazole are effective against the cystic phase only. Then miltefosine, highly effective, but it is very expensive. And NSAIDs are used when there is severe corneal inflammation, limbitis or scleritis. In cases of acanthamoeba, generally surgical treatment is required when there is extensive epithelial involvement. You just remove the epithelium debridement and you remove the most of the organisms, and it is very effective if performed early when the disease is intraepithelial. Then in later stages, penetrating keratoplasty is the only option when there is therapy-resistant infection, severe stromal melting with tracer perforation, and fulminant corneal abscesses are there. Keratoplasty in case of acanthamoeba keratitis has generally poor results due to relatively large grafts with higher risk of rejection and recurrence of disease in the graft due to the residual viable cyst. So I just want to highlight these slides, but the main part is whenever you see a patient, normally it is a routine presentation, acute red eye. So we should always, it is a common presentation of patients coming to clinics, ophthalmology clinics, and it is majority are caused by acute and benign conditions which are self-limited and not serious to vision or life of patients. But every patient presenting with acute red eye should be carefully examined for the treatment of the problems which can be life-threatening also, like orbital cellulitis, penetrating ocular trauma, keratitis, sight-threatening problems, scleritis, uveitis, and acute angle closed glaucoma. Thank you so much for your patient listening.